Good afternoon, everyone. Welcome to this webinar entitled Pediatric Emergency Point-of-Care Ultrasound, Targeting Appendicitis, presented by Sathyaseelan Subramaniam. The AIUM is accredited by the ACCME. This webinar is designated for one AMA PRA Category 1 credit. By the conclusion of this webinar, participants should be able to understand right lower quadrant anatomy and relate it to point-of-care ultrasound technique for appendix visualization, identify the features and appearance of a normal appendix on point-of-care ultrasound, and identify the features and appearance of an inflamed appendix on point-of-care ultrasound. As an ACCME accredited provider, it is the AIUM's policy to ensure that the contents and quality of this activity are balanced, independent, objective, and scientifically rigorous. All individuals who are in a position to control the content of an educational activity are required to complete a disclosure form. All disclosures are reviewed by the AIUM, and any conflicts of interest are resolved or managed prior to an activity. Sathyaseelan Subramaniam and Darcy Belito de Luna have no disclosures. At the conclusion of the webinar, you will be able to access the CME test and evaluation located on the AIUM website. Participants who complete the post-test with a grade of 70% or higher will be awarded one CME credit. For more information on accessing the CME test and claiming credit, please refer to the handout provided in the dashboard on the right side of your screen. Credit for this webinar are approved for physicians, sonographer, and radiologic technologists. During today's presentation, if you have questions for the presenter, you may type them into the question box on the right side of your screen. You will be able to submit questions throughout this webinar, but the presenter will not begin answering until the end of the presentation, at which time he will answer as many questions as possible. A recording of this webinar will be available on the AIUM website. And now I'm pleased to present Sathyaseelan Subramaniam.
Okay, good afternoon, everyone. My name is Sathya. I'm a Pediatric Emergency Medicine Ultrasound Fellow at the Children's Hospital of Philadelphia. I'll be talking to you about point-of-care ultrasound to target the appendix. I have no disclosures to make. In terms of objectives, we're going to go through a review of the anatomy of the right lower quadrant and how it relates to point-of-care ultrasound's technique to identify the appendix. Then we're going to move on to identifying the features and appearance of a normal appendix, and finally identifying features and appearance of an inflamed abnormal appendix on point-of-care ultrasound. So I'm going to start off this slide here with a systematic review that was published this year by some of my colleagues in the point-of-care ultrasound world that essentially looked at a whole lot of articles to try to find out the sensitivity and specificity through a meta-analysis of point-of-care ultrasound to identify the appendix and appendicitis. They looked at about 5,000 plus articles and whittled it down to 20 or so that met the inclusion and exclusion criteria. And they found that the sensitivity was 91% and the specificity was 97%. Out of these 21 articles, some of them were performed by point-of-care ultrasound users that were from the GI physician group and from the surgical group. If you just narrow it down to point-of-care ultrasound used by emergency physicians, the sensitivity was 80% and specificity was 92%. Now, overall, with a sensitivity of 91% and a specificity of 97%, these are pretty good numbers and kind of argue to use point-of-care ultrasound to rule in the inflamed appendix. Now, with emergency physicians, the sensitivity here is at 80%, and one can argue that that value may not be a good rule out for point-of-care ultrasound for the appendix, and so we have to use it with caution in that respect. Saying that, however, I want to be clear that as you use the ultrasound more and more, and you become more and more facile with it, your operator characteristics can improve, and so that sensitivity and specificity may increase, and so it may perform better in your particular hand. Now we're going to go into the anatomy. The first step I'm going to talk about is this traditional point to find the appendix, McBurney's point. So traditionally we palpate McBurney's point, which is 2/3 down the line that is drawn from the umbilicus to the anterior superior iliac spine, and it's supposed to identify, for the most part, the area of the cecum and the appendix that comes off the base of it. But we know that the cecum has a variety of different locations. It can lie up in the right upper quadrant, and it can lie further down in the pelvic brim. And along with that, the appendix has a variety of different locations as well. Almost 40-ish%, so 43 to 44% lie retrocecally, and this can be a challenge for point of care ultrasound or the ultrasound to locate the appendix. There are methods, and we'll talk about that in the end, to kind of help find the retrocecal appendix. But for the other 50%, they lie all around the place, further down in the pelvis. They can lie around the ilium, or even drape over the iliac vessels as well. This is a picture where we've removed the abdominal wall, and I wanted to give an idea of how things are going to look like when we put that ultrasound on and what we expect to see. So initially, when you put your ultrasound, which is the transducer, you're going to have small bowel on the right hand of that ultrasound screen. As you can see here, it's small bowel, and for the most part, the ascending colon is going to be on the left hand of that ultrasound screen, and so it correlates well. It's on the left hand on this diagram as well. It's at the right lateral position, and you can see the appendix coming off the base of that cecum. Now when you remove the small bowel, this is an important feature here that I want to highlight. The iliac vessels kind of snake under the appendix that is coming off, again, the base of the appendix. That's an important landmark to identify, and I want to show you how close it is in proximity. And then finally, when you remove the large bowel, the psoas muscle is really posterior down here. It's lying behind the iliac vessel that's been removed. And so that's really posterior. And you can imagine you have the ultrasound on, the psoas muscle is also going to be lying really posterior to those vessels. And these are all important landmarks when we look at point of care ultrasound for finding the appendix. This is a paper published by Dr. Sivitz's group down in Newark, New Jersey. And in his paper, he talks about a very thorough technique that I use to help find the appendix. Essentially, you're going to use here the linear transducer. The indicator marker is going to be on the right hand of that patient. So around here, and you're going to start off in the transverse orientation. You're going to slide from the umbilicus. You're going to slide from medial to a lateral position. Try to get that ascending colon. Once you find it and you're happy that you are on colon, you can come down the ascending colon. You're going to track that down all the way to the cecum. And then the highest yield area, which is where the anatomy that I've just kind of gone through, all those landmarks are going to start popping up now. As you slide through step number three, the first thing you'll notice is that you'll come through psoas, and then iliac vessels are going to be lying here. And this is where a lot of the times you might catch that appendix. Step 4, if you're still not finding the appendix when you're doing this, you can scan upwards, again in the transverse orientation, and then you can even go down further if you're still not finding the appendix towards the pelvis, and you'll end up seeing the bladder if it's full. And if you're having no luck, you finally want to flip that linear transducer, the high frequency linear transducer with the indicator marker now cephalad, and you're going to make a sweep right across this whole right lower quadrant in the hopes that you'll find the appendix, because it can be difficult sometimes. Now this is the one technique that I use and I've been using, but for older children and the adolescents, one way to get right onto that appendix, if they're complaining of pain in the right lower quadrant and they're able to identify it with, they can point to that area with one finger, and that's really where it hurts. You can go ahead and put that linear transducer right over that area to see if that's where you're seeing an inflamed appendix. So that's one way to find an inflamed one. And then before we move on to the ultrasound clips in this presentation, I want to go through one last anatomical image because it's relevant to what we're looking at on the ultrasound screen. This is a cross section essentially taken out in the area that's the high yield area, and I want to go through the layers that we're going to see. It's going to be skin, so the ultrasound is going to be right here, and it's going to be shooting down an ultrasound beam right through the abdominal wall into intraperitoneal content right here. So as the ultrasound beam is cutting through, it's going to go through skin, subcutaneous tissue, and then a layer of muscle. There are actually 3 layers here. It's going to be the external and internal obliques, the transverse abdominis, and then finally it's going to be the peritoneal lining here. And then deep to that peritoneal lining, you'll end up seeing bowel. Now, as we go from lateral, so right lateral to medial, you will see that there's an aponeurosis that then goes around and wraps around the rectus abdominis muscle, which we'll also usually see, and I'll point that out to you in some of the ultrasound scans when you're looking for the appendix, how close the rectus abdominis is to the peritoneal lining, and further down you can see usually bowel underneath that peritoneal lining. All right, so moving on, this is kind of what I was talking about in terms of layers. Before I play this clip, we're just going to go through some of it. So skin, subcutaneous tissue, all of this is going to be muscle content. And then from here onwards, this line here is the peritoneal lining. Now, these hyperechoic areas that you can see, this is air in the ascending colon. This is a patient that I'm kind of scanning down that ascending colon. So as I'm going down, you will see breaks in that hyperechoic line, and that it reflects the haustra of the normal large bowel. So the ascending colon will have haustra, and so the hyperechoic lines will have breaks in it. I'm going to play that clip now. Here we go. So here's hyperechoic line. There's a break. That's one haustra, and then again hyperechoic line. I'm going to play that again. You'll see underneath these areas of hyperechoic bright white lines that it's air, so you're going to get some dirty shadowing that comes down. And that can sometimes obscure good views of things. So one of the things that I'll emphasize during these ultrasound scans, and again at the end, is how we have to always utilize good amount of compression, so graded compression as we do these scans. We're going to take a look now at the area that I was talking about, the right lower quadrant. So you're going to use the linear transducer and move from right lateral all the way to medial. So this clip is going to show what that looks like as you transition from right lateral towards the medial area, where you're going to go through a lot of relevant anatomy. So skin, subcutaneous tissue, and muscle, and then intraperitoneal lining right here. You're going to see large bowel here, most likely cecum, and then the psoas muscle right here is going to come into view, and as we move further and further medial, the iliac vessels are going to turn up on this side. I'm going to play this clip right now. So cecum right here, psoas muscle, and then the iliac vessel is going to pop into view. You can actually also see small bowel here. This is not the appendix. This is actually small bowel, and I'll show you why. I'm going to play this clip again. It's actually, as you relax on the pressure, this caliber of this bowel is actually pretty big, and then as the transducer moves across it, catches it and compresses it. So we're going to play that again. Large bowel, psoas. This area here is all small bowel, and then as compression goes on, boom, it brings in that small bowel, and it's kind of over that iliac vessel. We're going to have to prove that this is iliac vessel, so I usually put some color doper to make sure that I'm happy that this is iliac vessel. And then, like I was saying, rectus abdominis, it's right up there. See how close everything comes together when you're putting compression. And I'm going to overlay it with a schematic diagram to kind of just highlight finally the different layers that we're going through to put everyone on the same page here. So skin, subcutaneous tissue, the external and internal obliques, the transverse abdominis, the aponeurosis that wraps around the rectus muscle, which I've shown you, the iliac vessels, and then this large piece of muscle, the psoas muscle. Here it also points out the iliac crest. I just want to make note that when we are scanning, rarely am I actually finding that iliac crest because the depth, I usually don't start off that deep. Well, actually, I do start off that deep if I'm having trouble finding the appendix, and then I usually, once I find it, I start to get really, I start to zoom in on that area that I'm interested in. So I actually rarely ever get to see that iliac crest. But this, in general, is how things are going to look like in the high yield area. Now we're going to go through some images of the normal appendix. and I want you to pay attention to this clip. The right-hand side is really the area that you're going to pick up that appendix. Here's all going to be ascending colon, or even cecum right there. So so you can see the host right here. This is cecum, and then this area of bowel looks different from the cecum. I'm going to play it one more time, and it's right up against that cecum, so it's abutting it. This is actually the appendix that's being seen in cross section. Once you find that appendix, you're going to then turn 90 degrees to find it and to view it in long axis, and to see if you can find the blunt end. Now, before I play this clip, this is exactly what's happened. So that's patient's appendix. I've turned 90 degrees on it, and the finger-like projection here is the appendix. This is the blunt end of it. I'm going to tell you that this is the psoas muscle right underneath the appendix, and again, abdominal wall right up there. So pay attention to this finger-like projection in long axis. As we were playing that, you'll notice there's a bright white line here too, and that's actually air trapped in that appendix as it comes off the cecum, and you can see some dirty shadowing as well. This is another clip of a normal appendix that I'll play, and it'll become very obvious. This is where it's going to come up. It's lying within areas in the lower abdomen, the right lower quadrant, where cecum is close by. So it pops into view occasionally. This is going to be the psoas muscle here on the right side. I'm going to go back there, okay, and I'll play that, and you can see how it pops in with graded compression and fanning. It is more apparent there, and adjacent to it is the cecum and small bowel. There's some peristalsis going on, so there must be small bowel there. And again, this is all shadowing that's obscuring the view. So when you're getting this, when you see this kind of a issue turn up, what you want to do is really hone in on that area, and then as much as you can, put some steady pressure on that area to try to bring up that appendix right up against that wall. And this is what happens when you do that. So cecum right beside it, and this is a nice, clear, visualized appendix. And the psoas muscle is to the right-hand side, right there. Okay, and then we're going to move on to this important paper that was put out last year by leaders of the PEM, the Pediatric Emergency Medicine Point of Care Ultrasound field. They came together and wanted to summarize the applications that point of care ultrasound uses in the pediatric emergency department, and with that develop a framework of how we should be reporting these different uses of point of care ultrasound. And one of it that was touched on was point of care ultrasound for the appendix, and they went through way to kind of standardize that approach. So usually we always start off with demographics, and then here's where the meat of that reporting really is. When we're looking for the appendix, we always want to make a comment on whether we're finding it in short axis and long axis, and it's important to locate the blind end. This is the reason this is important is because sometimes there are times when I've seen small bowel and ileum that can, under compression, appear very similar to a normal appendix. So if you find the blind end, though, you're convincing whoever is reviewing your clips that this is truly the appendix that you've located. So it's important, if you can, as much as you can, you want to try to locate the blind end. It's tough. Not every time you can get this, but if you are unable to, you just have to say, you're not able to. When you do find the appendix, you want to say it's visualized, and then you want to make measurements of the AP diameter of that appendix. So the standard currently is put at 6 millimeters as a good way of telling if it's an abnormal or normal appendix. So essentially, if it's larger than 6 millimeters, you're worried about an inflamed appendix. But if it's less than 6 millimeters, then it's one part of the puzzle to say that it's not leading towards appendicitis. Saying that, there is data that says that if you have an appendix that's less than 6 millimeters, but then has all these other secondary features with it, like an appendiculate, you're seeing free fluid and periappendix inflammation. Now, these things, along with a patient that's really tender when you're looking at the patient's right lower quadrant, that's all very concerning for appendicitis. So I wouldn't say I'm confident that it's not more than 6 millimeters, it's only 5, it can't be appendicitis. I'd be very cautious about saying that it's probably appendicitis because everything acts like an appendix, like an appendicitis. And then there are times when you're finding appendices 7 millimeters or 8 millimeters, the patient's not really in pain anymore in that area, and you're not getting a lot of secondary features. Now, if that happens, again, you can't use just this cutoff mark above 6 millimeters as a reason to call it appendicitis. You have to put the whole clinical picture together. The next thing that's important to do is try to compress the appendix. Essentially, we're saying if it's compressible, it's a way of saying that it's unlikely to be appendicitis because it's compressing very well and it's less than 6 millimeters at that point. Sonographic McBurney's is very similar to sonographic Murphy's. It's when you are visualizing the appendix directly under your linear transducer or your curvilinear if it's a patient that you needed more depth on. And once you find that appendix under the ultrasound, you then compress. And if the patient is tender while you're doing that, that's a sonographic McBurney's that's positive, and you're going to make note of that. That is suggestive of appendicitis. An appendiculate is also pretty specific for an appendicitis, but not always is a patient with an appendiculate going to have appendix. But they say that it's more specific as a marker for appendicitis. This is essentially the way you're going to pick this up is when you're looking in the appendix, the lumen of the appendix has an hyperechoic line with a lot of posterior acoustic shadowing. And I'll show you all these different secondary features. I'll show you in each clip where we've got positive appendicitis clips, and we'll go through each one of them. Periappendix inflammation is very common, and it's an important marker to suggest inflammation going on. It's essentially when things get a little hyperechoic in the tissue around the appendix. It is usually mesentery or fat that's inflamed that gives that appearance. Free fluid, you will see this as well. I'll show some clips of that around the appendix. And peritoneal abscess. If you locate a peritoneal abscess, this is suggestive now of a patient that's perforated that appendix. And so it's harder to locate the appendix once it's done. And you'll see this in the clips that I'll show. So first up, normal appendix, and we're going to talk about, we're going to do the standard criteria where we're going to do the long axis, the short axis, and then we're going to do measurements and compression. And I'm going to play this ultrasound clip, and you're going to see the iliac vessel is going to be on this side, and psoas muscle is going to be on the left hand side of the screen. So iliac vessel is here, and I want you to pay attention to something that's going to be approaching. Here's the iliac vessel, and I want you to pay attention to this thing over here and see how it kind of goes over the iliac vessel. We're going to just do that one more time. So right here, this is the appendix, and this is the iliac vessel. And as I play this, as I kind of drag this clip, you're going to see the appendix is going to flop over the iliac vessel right there. So once you have an idea of that being the appendix, you're going to zoom in to get a more clearer view of it. So here's us reducing that depth in the right lower quadrant, and this whole thing here now is the long axis of an appendix overlying that iliac vessel. I'm going to play this here. So this is all appendix. And then we're going to try to find that blind end. And the blind end is seen very briefly, but it's right there in the end of that clip. And then we're going to turn 90 degrees to find it in short axis. So I'm going to play this here. This is an appendix here in short axis. And it comes in and out of view because we're doing some compression as we are looking at it in short axis. And you'll notice also that the iliac vessel is here in long axis. So I'm going to show you what it looks like when we are not compressing. So here's when I'm not compressing, and I kind of relieve, so I kind of take the transducer off a little bit of pressure, and so the appendix falls down deeper into the abdomen, and it becomes less and less clear. It's not as defined. And as I put more pressure on that area, it brings it right up against that abdominal wall, and you see the clarity of all the different layers of the appendix, which I'm going to talk to you about, and why we see that. We make a measurement. So it's less than 6 millimeters. This is 3 millimeters. So we have now an appendix there that we're convinced of. We saw in the long axis, the short axis. We saw a blind end. We showed it's compressible, and we measured it. So this is a good way to do your appendix point of care ultrasound. In terms of the layers, you might be wondering why we get these layers when we're looking at the appendix, and it's all got to do with the alternating muscle layers and fatty layers. So in the outside, we usually get that serosa, then the muscularis externa, submucosa, and then we have the muscularis mucosa, and finally the mucosa itself, and sometimes air in the middle of it, and so it becomes hyperechoic when air is trapped in it. So that explains the layers that we see in the ultrasound clips, which are going to be more clear in some of the other videos that I'm going to show you. And this is done on a different machine, and some machines, depending on how you set it up, they can give you different difference in the clarity of that appendix. So here's one that I'm going to play. This is a short axis of an appendix. This is the psoas muscle here, and we are going to see some large bowel, so likely cecum, and some small bowel on the right-hand side. So this is all abdominal wall, and this is the peritoneal lining right here. So I'm going to play that one more time. So you can see you're getting a view of that short axis. And now what you want to do is turn it on long. So you turn 90 degrees on it, and you can already see this here has a blind end to it, very, very clear appendix, and the psoas muscle right underneath it. The one thing I'd want to point out while we're looking at the scan is to notice all the structures around it. So like small bowel underneath, the psoas muscle, it's all really clear. And the green arrow is obviously pointing to the appendix. Above it is bowel as well. And it's all very clear. Nothing's really that bright. So this is when you have no periappendiceal inflammation. So this is, again, a normal appendix. Just like all the other appendices that I've been showing you, they've all been normal appendices in patients. This is a clip where I'm doing compression in the long axis. It's not usually how I'd recommend doing compression. If you can do it and you can prove to yourself that the walls are coming together, that's great. But it's easy to do in the short axis. You can turn that probe when you're on the long axis, turn it back to short axis, and then compress and see the walls are coming together. But here we are. I'm going to show you that the walls do come together when I'm compressing right there, and I'll do it again. The walls come together again like that. So that's a compressible appendix, unlikely to be appendicitis, especially because of the lack of other features. And then boom, another compression here that we've shown. So normal appendix, for a variety of reasons, it's compressible. You're seeing no periappendiceal inflammation, no free fluid around. We make a measurement as well in this patient. The same patient has a appendix that's less than 6 millimeters. So very reassuring. This patient that I'm scanning here is interesting in a way, and I'm going to play this clip. You can see here that this is the iliac vessel, and this is the psoas muscle. So iliac vessel, psoas muscle, and then this is the structure of interest right here. This is the appendix. And right up here is a psoas muscle. Sorry, right up here is the rectus abdominis. The psoas muscle is on this side. And I'm going to go to the next clip. As we are scanning in the transverse orientation, this appendix is going to dilate at the end. So right at the tip, kind of in the distal appendix, it dilates almost as large as the iliac vessel that's sitting right against it. And this is always concerning when I see that for two reasons. One is I'm not entirely sure when I'm doing this if I'm actually scanning terminal ileum or another piece of small bowel, or maybe even that this patient actually has got tip appendicitis, which is a phenomenon where there's the tip of the appendix is inflamed. And so one way to prove, number one, that I'm not having, that I'm not scanning a terminal ileum or small bowel is to really locate that blind end. So here's what we do. We turn it 90 degrees, and I'll tell you that this here is the appendix, and then it starts to dilate right about here with a blind end. So it has this bulbous top to that appendix, and I'll play this clip. In long, you're going to see the iliac vessels now are no longer in cross-section. They're in longitudinal sections here. The green arrow is pointing to the appendix. So notice how it's nice and clear, and then it has this bulbous look to that appendix here. Now, it's important, so we're pretty confident that's the appendix. It's not terminal ileum, it's not small bowel. The next question we really have to do is we have to measure that, dilated portion, and we're going to have to see if it compresses. So here, this is where we're looking at it, and we're starting to compress. So that's one, that's two. I'm trying to make sure the patient's not in pain in that area, and I'm proving to myself that I'm happy that this is all being compressible. So right here, this is me when I'm not compressing, and then this is me when I'm compressing. And see how the walls come together? So I'm pretty happy that while I'm doing this compression, the patient's not in pain and the walls are coming together. It's unlikely that an inflamed appendix is going to allow me to do that, to be able to make it as compressible as it looks like here. We make a measurement at the area that's dilated. The area that says dilated is an iliac vessel, and it's still less than 6 millimeters. So all very reassuring for a normal appendix. Now we're going to move on to the abnormal appendices. So I'm going to play this clip, and you're going to see this structure here. This is the structure that's of interest. We're worried that this patient is actually tender in that area. And we turn from the short axis, we're going to move on to the long axis. And I want you to see how the difference in the clarity of this appendix is now kind of, it's not as clear. The layers have seemed to disappear. The blind end actually is kind of, it's diving deeper into the abdomen. So we're not getting a great look at that blind end of an appendix, but sometimes that happens, and we have to work with what we've got. So on this side of the screen, the right side of the screen is when I'm not compressing the appendix. And the left-hand side of the screen is me compressing the appendix, and I make a measurement while I'm compressing. And if you look in the right lower hand corner here, it says 7 millimeters. So this is a patient who is not really being able to compress the appendix. There's not a lot of difference in the diameter here. In fact, it's actually larger on this side. And while I'm compressing, it's still more than 6 millimeters. The patient's in pain in that area, so has sonographic McBurney's. So this is all features of appendicitis in this patient. This is another one that's more obvious, and I put this here because I want to highlight a very important secondary feature. This is periappendiceal inflammation all around here. There are three structures here that look like they're separate, but they're actually all one and the same. This is an appendix that's kind of curling over on itself like this, and as I play the clip, you're going to see how it kind of comes together. The first clip, though, when I'm playing, is me trying to compress it, and I'll show you while I'm playing it, nothing really is compressing, and the patient states that they're in pain when I'm doing that. None of these, the diameter of this is not really changing when I'm doing that. And when I'm playing, look at this, how this kind of, it's connected to that, and this is connected to this, and then so it's all one and the same, but notice how bright and white the soft tissue is around this appendix. It's inflamed because the mesentery is all getting inflamed from the appendix that's in the right lower quadrant that I'm scanning. We make a measurement of this structure, and it's more than 6 millimeters, and we turn in a long axis, again kind of showing you that it's curling on itself. It's more than 6 millimeters as well. So this patient's got appendicitis. This is a different patient, and I wanted to highlight this clip because we've got that second a feature called free fluid around the appendix. So in long axis, you don't really see it. You just see an appendix here with hyperechoic soft tissue, which is basically periappendiceal inflammation. I'm going to play that clip, and it becomes more clear. Right here, it's all inflamed, and this appendix and long has no free fluid, but it's always important. This is why we always do it in two views, because the minute you turn it in cross section now, you start to see this anechoic area that's actually free fluid with the pointed tips right there. It's falling in the recesses of the small bowel and potential space. And as I play it, you will see the periappendiceal inflammation, and then right here, this is the appendix that we're looking at. You make a measurement, and it's more than 6 millimeters. And again, note the free fluid on this side of the screen as well. And this is case 4, and I'm bringing this up in curvilinear. It's not the linear transducer anymore. It's a curvilinear footprint that you can see. It's because when I was doing the scan, I was unable to tell what I was really looking at, and so I wanted greater depth to see all the different structures. And this is the bladder on the right-hand side of that screen, and this area that I'm interested in is this kind of hyperechoic circle here, and it could be a vessel, so I throw on some colored Doppler on it. It's really not pulsating. There is some periappendiceal inflammation around the structure, and I'm worried that could be the appendix, an inflamed appendix. So I switch out to my linear probe, and I'm going to see if I see any features that are worrying. So number one, the clarity of this appendix is gone. It's not the usual multi-layered appendix that I usually see, and also I get to see the periappendiceal inflammation much better now. I put some colored Doppler on that again, and this is really to show you a sign called the ring of fire sign. So around the wall of the inflamed appendix, there's going to be more blood supply because it's inflamed. So there's increased vascularity, and when you put colored Doppler on this, you get this interesting look to it where it starts to, around it looks like this ring of fire sign. And that's it's not a definite marker of appendicitis, but it's one feature that people talk about that can help you find inflamed appendix. This is it in long, and we'll just look at that long. Again, you see things moving down like small bowel, but nothing is moving here, so no peristalsis. So you're pretty confident that is the appendix. You make a measurement, it's more than 6 millimeters. This is appendicitis until proven otherwise too. This is a great case. I always like going through this video clip with learners. It's this hyperechoic structure here is an appendiculate, and it's got posterior acoustic shadowing. It's lying within the lumen of an appendix. When I start playing it, you're actually going to see two appendiculates. This is nearer to the base of the appendix, and as we scan in the transverse orientation, this is going to be in the transverse orientation. As we scan further and distal to the appendix, we'll start to get a much smaller appendiculate, and I'll just play that right now. So this is all appendix in cross section, and then that's it, and another appendiculate at the tip. Notice also when I play this, you get a lot of other secondary features too. There's some hyperechoic mesentery, periappendiceal inflammation essentially as another feature of appendicitis, and you're going to see some free fluid as well right here. Yeah, so right there you see some free fluid, and I'll show, and I'm going to go through this again slower just to show you that second appendiculate. So right, we're going to go back all the way here. So that's that second appendiculate with some posterior acoustic shadowing. So right here, this hyperechoic structure within the lumen of the appendix that's inflamed. You can see some shadowing coming down, and then as we go further down this clip, you can see some free fluid as well, just adjacent to the inflamed appendix. And then right here is this massive appendiculate located within a huge inflamed appendix. And we're going to do this in long axis again, and you're going to see this appendix really has lost all its clarity and all its layers. You can see this massive appendiculate here and another one right at the distal tip. So you get both these appendiculates within one inflamed appendix that's looking all lumpy, and periappendiceal inflammation that's very obvious as well right underneath there. We make a measurement of it in the short axis, and it's huge. It's almost double the size. It's actually double the size of a normal appendix. It's 14 millimeters. The other features that I'd like to talk about in appendicitis is when you start to get dilated loops of bowel. So this is a patient that had come in, and I'm using a curvilinear probe. This patient has been complaining of right lower quadrant pain, and when I put the probe down, this is what I'm getting. You can actually see some to and fro motion of bowel content. So right here, it's kind of going this way, and then it's again going the other way. And this is a patient that really is vomiting with right lower quadrant pain and got dilated loops of bowel now. And then as you scan, there's really no peristaltic activity of the actual bowel. This green arrow is pointing to the bowel. And then you go into the sagittal view, and so you see the bladder here. This is the bladder and sagittal view. This is the pubic symphysis coming with some shadowing down there. And this is bowel here, but right around it, adjacent to both bladder and bowel and bladder, is this area of free fluid. So you can see the pointy edges right there, and then this side is kind of outlining the bladder. So the arrow is really pointing to that free fluid. So you've got dilated loop of bowel with some free fluid and a patient in pain. Although you're not seeing the appendix, this is someone that you want to at least be suspicious about something going on in the abdominal cavity. Which could be, it's not specific for appendicitis, but it certainly could be appendicitis or something else that's irritating abdominal bowel. Perforated appendicitis. Now, I'll show you this clip. This is a tough one to interpret because a lot of times you're looking for the appendix and you're trying to figure out if this is appendicitis. But when you see this, you have to get worried that maybe this is now a collection. So a heterogeneous collection that could be a perforation. You're in the right lower quadrant, and I'm going to drag this clip back, and you're actually seeing some air right in the area that we're scanning. Right here, it's almost like there are A-lines that you typically see in lung. So this whole area it's a heterogeneous mass-like quality in the right lower quadrant with some A-lines in the patient's pain. That's all really concerning for maybe a phlegmon or an abscess due to a perforated appendicitis. This is another still clip, but you can imagine how a provider who's using point-of-care ultrasound can be easily fooled to think this could be something else. And it's easy to make call this interception if you're not paying attention to all the different kind of features of interception cell, which is going to be a talk that I'm going to have in February of 2018. I'll go through that. But this was actually initially, this scan was called interception, which was then found out to be perforated appendicitis. All right, another feature of perforated appendicitis, clear peritoneal abscess. So this is a curvilinear probe looking down to the pelvis in sagittal. So the bladder again is here, pubic symphysis is here, and I want you to pay attention to this area here. This is concerning for an abscess. It's not immediately obvious to everyone. Sometimes you can think, hey, you know what, maybe this could be bowel with some stool in there, but you'll notice there's no peristalsis going on, and also it's really deep into that pelvis that we're talking about, and you can't really tell if there's bowel wall here. And the other thing, in the transverse orientation, you're seeing the bladder in transverse, and this area here is that collection that we're worried about. You're actually going to see some air rising within it, which is very atypical for a bowel to behave. If you look at this, there's some hyperechoic dots that keep rising up within this collection, and I'm going to stop there and drag that one more time to show you. It's such a unique look to this that is concerning for a perforated appendicitis with a collection that's have gases obviously coming through from bowel due to the perforation. All right, so that's a lot of abnormal appendices there. I'm going to go through one of the questions that comes up when you are scanning. What happens when you don't see the appendix? What are the outcomes of these children? And then the next question is, what if you're not seeing it, but you're seeing secondary signs, and many of those that we've already looked at? What happens when you see these things? And as a point-of-care ultrasound provider, I have to be aware of my limitations here. So 10 to 30% of all studies, even in comprehensive ultrasounds of the appendix, there's a chance that they're not going to find it. And so a lot of institutions have different rates. It can vary from 10 to 30%. But essentially, those two papers that I showed you in the previous slide, they talk about how if you're seeing secondary features like free fluid, phlegmon, periappendiceal inflammation, or lymphadenopathy, you start to increase your odds of there being an abnormal appendix in the area. So when you start seeing that, as a point-of-care ultrasound provider, if I'm not seeing the appendix, but I see those secondary features, I get a comprehensive ultrasound. Or if I'm in an institution where I don't have comprehensive ultrasound, then I have to think of other forms of imaging or getting help from my consult services. If there are no secondary signs, but the exam is still not reassuring, the patient's tender, vomiting, unable to tolerate PO, these are all reasons for us to step back and say, hey, I'm not seeing any secondary signs, but the patient's behaving like they've got appendicitis. So again, make sure you utilize your resources in your institution, get the consult services, or get other types of imaging. It could be MRI, it could be CT scan, if you do not have comprehensive ultrasound, which is in a lot of institutions is your first choice in the pathway. And then the idea of the non-visualized appendix in a patient who doesn't have secondary signs and is now clinically changed in terms of like they seem better after given some time. The exam is no longer concerning. The paper, one of those papers that I had shown in the previous slide, actually talks about how they discharged a fair percentage of these patients that they didn't visualize the appendix, didn't have secondary signs, and the exam was not as concerning. They had a very low rate of returns for appendix. So it's a possibility, but the other possibility is just bringing those patients in for serial abdominal exams to see how they progress. You can also let them go home with strict return precautions, saying that, hey, if any of these things happen to you while you're at home, please come back to us. Now I'm going to go through some final images of mimics that have fooled me in the past. This is one where I'm looking and I'm trying to find the appendix in a patient. I've got my landmarks here. I've got the iliac vessel. I'm like, oh, hey, this could be the appendix. But I'm not sure. I feel like, this is a little atypical from all the images that I've shown you. It's a little bit more kind of not as nice and vermiform. It's not clean in its contours. So I zoom in a little bit more, and we're looking at it. And again, I'm like, every time I release some pressure, it seems to dilate quite a bit. I'm not really confident. Then I notice this thing right underneath here, and the green arrow is pointing to it. And I'm suspicious. You know what? I actually think maybe that could be the appendix, and that could be terminal ileum. So you focus on that area, and now you really bring this up, and this is actually the appendix lying right underneath the ileum. So it's an easy one to get fooled by, and I've certainly looked at some of my scans from the past and thought, hey, I actually think that was a terminal ileum and not the appendix. So just beware. Try to find that blind and prove to yourself that you're not catching small bowel. This is measured, it's less than 3 millimeters. And then one last shout out to good graded compression. So this is a patient that has tenderness in the right lower quadrant. The resident is scanning. She's on the right area of the patient. You can see those iliac vessels, and she thinks she's seeing something here. And I totally agree. I'm worried about right on the right-hand side of this iliac vessel. I'm worried there's something going on there. So what can I do to optimize this image? I can certainly reduce the depth if I compress really a lot more on the patient. The patient, you can manage to give good compression if you get their pain under control. So think about some analgesia before you go ahead and do that graded compression. And so now with that, we've dropped the depth down to 4 cm. Previously, it was about 6 cm. We've tried to optimize our focus position. And so this is kind of iliac vessel underneath. And I want you to focus on this area right here. That's what we are starting to look at now. And that looks like it's the appendix. That's looking like appendix. It connects to something here. And I'm going to trace that. And it's going to be the cecum. So in the next clip, we show that this appendix is going right up to the cecum. It's hard to find the blind end of this appendix because bowel on the right-hand side keeps coming into view every time we try to get it. So it seems to dive in. So right here, it goes over the iliac vessel and it dives underneath, and then bowel gas comes in the way. But I want to go back to this area here where we are having cecum, and it's connecting. So this is cecum here, and it connects right up to the appendix right here. So appendix, cecum, and then it connects. So at least we can prove that it's coming off the cecum. We just can't prove that it's the blind end. Now we make a measurement right above the iliac vessel, and it's 8 millimeters. So a patient who's tender, you can see that appendix, and they are more than 6 millimeters. This is also appendicitis. So in summary, I'd advocate for looking at the appendix with point-of-care ultrasound, using the landmarks that you understand in the right lower quadrant, keeping an eye out for that psoas muscle and those iliac vessels. You're going to use a systematic approach. If you're getting lost, use a systematic approach published by Adam Sivitz in his paper. It's a really good way to start off learning how to use the ultrasound. Once you find that appendix, visualize it in the short axis, look at it in the long axis, do some good compression, and then go ahead and measure it. And then again, if you're seeing secondary features, unable to see the appendix, please go ahead and get a comprehensive ultrasound to help you locate that appendix if it's truly inflamed. And then I always like to end my presentations now to new groups with this slide, because I love my linear transducer here, and I think it should be used just as often as we are with the ophthalmoscope and the otoscope. For the pediatric patient, it visualizes so many things that can help us with point of care of our patients. So to conclude, I'd like to thank my mentors, Aaron Chen and Rachel Rempel here at the Children's Hospital of Philadelphia for helping with this presentation, and my former institution, SUNY Downstate in Kings County, for a lot of the images that and amazing patients that I had the privilege of scanning and learning from. And I'll take questions. Hello?
Sathya, we do have one question. Are you able to see it in the panel?
Yeah, let's see. Is a retrocecal appendicitis diagnosable with the ultrasound? I think in very experienced hands, this is definitely possible. There are methods where you, just like you are palpating, for example, in flank pain, you slide your hand posteriorly. You can do that closer down in the right posterior part of the abdomen, and then push upwards to try to bring the retrocecal appendix out behind the cecum. So it is possible. Now that's one way of doing it. I've seen Adam Sivitz. I actually he and I scanned once, and I learned a lot from him. And he showed me a method where you could use the linear transducer and kind of slide in a very you basically, instead of having your probe anterior to the right lower quadrant, you're sliding your probe lateral in the right kind of lateral position, and your beam is pointing right into kind of the psoas muscle area, but it's a lateral posterior approach, and that's one way of getting the retrocecal appendix. It is advised. So the second question is, do you always have to measure the appendix diameter with compression? I'd say that would be the best. If you look at ultrasonographers who are doing formal ultrasound scans, you can totally see that they are compressing that appendix and then making that measurement. So if it's compressible and it's less than 6 millimeters, I think, you could, like I said, it's very important to look at the other features around that appendix too. So if you're compressing, it's less than 6 millimeters, but the patient's going to have appendiculate and is in pain in that area and you can feel it, I'd use that with caution and say, this is probably appendicitis until proven otherwise too. So this is one of our questions coming from one of the leaders who helped with the paper that was published, and the question is, can you comment on appendix size in smaller children? Is 6 millimeters still standard for appendicitis? So there are a couple of papers that have actually been published about this, and one was from my former program fellowship director, who talked about how and she found an appendix that was 5 millimeters and is an appendicitis. So I can personally, in my experience, I think in terms of inflamed appendices, you can totally get it below 6 millimeters too, and especially if you have a lot of other features going on. I do think that the smaller and smaller children, like if you're talking about a neonate and an infant, I would say that there might be variations in the normal size of the appendix, and there's a lot of discussion on this that's going on. I think that we're going to get some good answers as we get more and more research into this area. I certainly think the appendix size varies and can sometimes fool us one way or the other. It can sometimes make us think it's inflamed because it's more than 6, and sometimes it can be less than 6 and it's still abnormal. Okay, let's see. So this is a good question. In a normal visualized appendix, when you compress, does it completely compress, or is it just has to be under 6 millimeters? So a lot of times, even when I'm compressing a normal appendix, I actually don't get the walls ever to completely come together. That's very hard. That requires a lot of compression. A lot of times, it's just the walls in the appendix showing that it's being compressible, and then you make that measurement. It's not always going to bring those walls together when you're doing the compression. And is there any requirement to measure the appendix in the long axis? I'd say that it's important to do it in the long axis because you want to try to find the blind end of the appendix. You could convince a reviewer in short axis if you're scanning and then you're going through the whole appendix in the short axis and then it falls off. But I think it's much easier for me to believe that you are looking at the appendix when you are looking at it in a long axis, especially when you're trying to try to convince me that you're looking at the appendix and you found the blind end. I think I'd believe a clip much better when I'm seeing it in a long axis. It is very difficult in some patients to get because the vermiform appendix is like a worm and it kind of has different orientations to it. So it's not always possible to get a good long axis view, but if you can do it, so I would always attempt the long axis. So at least in point of care ultrasound reporting, in that summary of the evidence, long axis is certainly something that we should attempt to do. The question is, if you see the appendix, is it always pathological? And I want to say that that's definitely not true. If you see the appendix, because a lot of us are seeing normal appendices now with point of care ultrasound, it is not pathological. If you're seeing a normal appendix, you certainly can find it with enough compression, with enough time. When I started off, it took at like 15 to 20 minutes. I just have to, and I usually end up doing it in these night shifts as things slow down, so I could spend time. So as you spend more and more time, you will find normal appendices, and that is certainly not pathological. Could you explain the usefulness of color Doppler in the diagnostic landmarks for appendicitis? I use color Dopplers sometimes in patients that have a lot of subcutaneous tissue and I need a lot of depth. and I'm seeing something that's in the transverse section, I'm seeing something hypoechoic, and it's near the psoas muscles. I'm sometimes unable to make for certain if that's an iliac vessel or an inflamed appendix. And I think in those particular situations, colored Doppler can read out immediately if you're looking in an iliac vessel, especially if you're using a curvilinear probe. Things as they get deeper are becoming less and less clear. One way of kind of making sure you're not mistaking an appendix by looking at an iliac vessel to drop the colored Doppler on. If you see pulsed outflow, if you see it lights up, then you know for sure that was not the appendix, that you were an inflamed appendix, that was just colored Doppler on a normal looking iliac vessel. Is there any relationship between the body posture and appendix AP diameter? I'm assuming that if you're saying sometimes if you're finding a patient who's lying in kind of like a lateral position, and if that changes the appendix AP diameter, I would say no. I think the AP diameter can change just by you doing compression itself. You can bring the AP diameter down, which is something you'd want to do to see if the diameter can be compressed. But I certainly don't think the positioning of the patient makes a big difference to it. All right. Is it always easy to distinguish air inside the appendix from an appendiculate? And I'd say, there are certain classic features that make you think one is an appendiculate and one is air. Now, when you have air, they both will share this hyperechoic characteristic in the appendix, but one's going to have some clean posterior acoustic shadowing, just like when you see gallstones. And for example, like when you're doing a lung scan, you're doing an ultrasound of lung and cross-section of a rib, it's nice and hyperechoic and has really sharp margins to when the posterior acoustic shadowing falls down. And when you have air in the appendix, although it has hyperecho, it can seem hyperecho, it is hyperechoic in the appendix, it actually doesn't have that clean posterior acoustic shadowing. It has this dirty shadow appearance of how air in large bowel or small bowel would look like. It's not completely obscuring and kind of black underneath that hyperechoic area. It kind of has a hypoechoic nature to it, and so I call it dirty shadowing, and I think a lot of my colleagues in the point of care ultrasound will call it dirty shadowing when you're getting air in the bowel, and that's what you would see in the appendix. I've heard that turning patients left lateral decubitus helps. Is that true? And I'd say that this is what one of the first questions was asked about, how you can locate a retrocecal appendix, and this is certainly a time when turning a patient left lateral so that you can position that ultrasound probe more posteriorly to get a view kind of through the psoas muscle to look at the appendix is useful. So yes, certainly. The left lateral can sometimes help for a more retrocecal or very lateral appendix.
Great. Well, we're going to need to wrap up at this point. So thank you very much, Sathya. And on behalf of the AIUM, our thanks to all of you who participated in today's webinar. Please remember to complete the post-test and the activity evaluation, and we hope you enjoyed this presentation and will join us again for future webinars. So long, everyone.